Hi everyone, I will be talking about irritable bowel syndrome, and today I will be talking about different types of irritable bowel syndrome, the symptoms, diagnosis, and differential diagnosis. You must be familiar with this term, right? But I'll go into details, and I may not be able to go over everything, including treatment right now, but you know what you are supposed to know as per the types, symptoms, diagnosis, and differential diagnosis. A lot of people are suffering and they need help. So get yourself educated so that you can help yourself and others around. Let's go. Irritable bowel syndrome subtypes. Irritable bowel syndrome with predominant constipation means there's irritable bowel syndrome, but the main issue affecting the individual is constipation, and it could be irritable bowel syndrome with predominant diarrhea, meaning diarrhea is the main problem, and it could be irritable bowel syndrome with mixed bowel habits, and the individual will have a quarter of bowel movement as constipation and a quarter of bowel movement as diarrhea. If you don't belong to predominant constipation, predominant diarrhea, or mixed habit, it could be unclassified. In that case, the characteristics of irritable bowel syndrome is met, but not able to be placed into any of the 1, 2, 3 above. So it's very difficult to put the individual to say, oh, the predominant problem here is constipation, or it is diarrhea, or it is actually mixed in equal proportion, but still irritable bowel syndrome. Irritable bowel syndrome is a gastrointestinal tract problem, and it is associated with abdominal pain, also bowel movements that could either be constipation, diarrhea, mixed. But there's one thing that is significant here. There is no organic cause. And you can't believe it. It's very common. It's very common. A lot of people will visit their clinicians based on complaints that will be related to irritable bowel syndrome. Irritable bowel syndrome has no specific abnormality, and like I said earlier, there will be altered motility of the bowels and also there's likelihood of hypersensitivity. There is inflammation and alteration in fecal, flora, and bacterial overgrowth. They may be having food sensitivity and of course genetic predisposition. So it could run in families. There's likelihood of high frequency and irregular luminal contractions, and if that is the case, the person will be having diarrhea. But in people with prolonged transit time, it will come down with constipation. If the issue is increased sensitivity due to cholecystokinin and meal, the individual will be having diarrhea. Hypersensitivity to gastrointestinal tract distension will lead to somatic pain and bloating complaints. So people with irritable bowel syndrome will be having abdominal pain and sometimes they feel bloated. Okay? When they have intestinal inflammation, they will come down with diarrhea. If the stool from affected person who is having predominant irritable bowel syndrome as diarrhea is taken, we are going to likely see high serine-protease activity. So, serine-protease inhibitors will prevent pain and diarrhea in them. So, if the treatment has become recalcitrant, I mean, someone with irritable bowel syndrome and diarrhea is the predominant symptom, take the stool for high serine-protease activity. And if you're able to pick that, grab one of the serine-protease inhibitors. Now, the patient might come back praising you forever. When there's high mass cells, there's going to be increased pain. That is why some of the medications we'll use when it comes to treatment will be the medications that could suppress mast cells release. Increased cytokinins will lead to more awareness of pain. Post-gastrointestinal tract infections will likely lead to increased irritable bowel syndrome. Contaminated water with E. coli will increase irritable bowel syndrome and here diarrhea. Someone will ask, if someone has acquired that, of course, you will have diarrhea, right? But if you are predisposed and then you are exposed to that, it's going to get worse. Malabsorption syndrome will lead to increased diarrhea, and antibiotic used for a prolonged period of time can lead to pseudomembranous colitis, leading to diarrhea. Now, of course, high functional bowel symptoms. So someone asked me, even if I've not been diagnosed with irritable bowel syndrome and I'm on antibiotics per oral for a long period of time and I've been diagnosed with Clostridium difficile, won't I be having diarrhea? Of course you do, but in individuals that have genetic predisposition to irritable bowel syndrome, or they've been having irritable bowel syndrome but not so pronounced, or they didn't know, just having that antibiotics for a long period of time is sure to bring down the diarrhea in them. Bacterial overgrowth, food sensitivity, or food allergy will all contribute to exacerbation of symptoms. Epidemiology. Functional disorder of gastrointestinal tract, irritable bowel syndrome is one. There will be chronic abdominal pain. There will be altered bowel habits, and 10 to 15% of North Americans have irritable bowel syndrome. It is less in 50 years old and anyone older than 50. But it's more in younger age group. In other words, if you are 50 and above and you are just having the symptoms and been diagnosed with irritable bowel syndrome, that's abnormal. I'm not saying you cannot have it after 50, but it's not very common. It's very common with younger age group, and it's found in male and female, but slightly higher in females. And when male and female will have irritable bowel syndrome, the females will likely have constipation more than the males. So women are more constipated. Irritable bowel syndrome could be associated with a lot of things. Here, you could be suspicious of abuse when you are dealing with a young woman with irritable bowel syndrome, predominant constipation or diarrhea, or mixed, or even unclassified. So the history will have to rule out any form of abuse in the life of this young woman, because most times they will not voluntarily offer that. So high index of suspicion will be very, very helpful here. Young women, with irritable bowel syndrome, let's rule out abuse, because they could be abused by their stepfathers or fathers or uncles or somebody close around, particularly sexual abuse. Fibromyalgia, particularly in older ones, 40 and above. Chronic fatigue syndrome, gastroesophageal reflux disease, functional dyspepsia, non-cardiac chest pain, because there is history of pain, right? Psychosis. In fact, I had a particular case of a father who complained to me and I was seriously mad at his doctor, his family doctor, because the family doctor suggested that the daughter might be having, psychosis or depression or anxiety. And the man was mad that, what was he talking about? And the man was even, that the physician was trying to rule out abuse. So he took an offense and launched a complaint to me. And I said, no, you don't blame the doctor. The doctor was actually doing the right thing. Because according to our books, irritable bowel syndrome could be associated with all those conditions. Then I told him, you better go back to the doctor and just smile and tell him you had second opinion and you are no longer mad at him. So it could be that bad. The man was mad at his physician, but it is actually true that when we see young women, young ladies with irritable bowel syndrome, we rule out all these things. Somatization is possible. Clinical features of irritable bowel syndrome will be based on two main features: chronic abdominal pain and altered bowel habits. All we are going to talk about clinical features will center around these two main complaints: pain and altered bowel habits. Now, as per pain, the abdominal pain will be crampy and there will be periodic exacerbations. The location will be variable and the characteristics will also be variable. It could be mild and it could be severe. By the time you ask about the scale from 0 to 10, it could tell you is 4, it could tell you is 9. I mean, 0 being no pain and 10 being the worst pain. Could be related to defecation. Many will tell you that they have the pain, and when they went to the washroom or giant or toilet, depending on where you are on the surface of the earth and what you call it, and after defecating, they will be relieved. That would be the classical ways that many will present. Some, even defecation will not lead to resolution of the pain. It won't resolve with it. The situation of affected people with irritable bowel syndrome could be aggravated with emotions or meals and could be associated with bloating, flatulence, and belching. So when you have somebody close to you who has been complaining about intermittent constipation with diarrhea or diarrhea most of the time, and they complain about bloating, and all the time they fart or they belch, now you can understand this person is likely having irritable bowel syndrome. Diarrhea. In those with irritable bowel syndrome and having predominant symptoms to be diarrhea, you can check my videos on diarrhea. Just check Total Vicar, check diarrhea. I think I have about 3 videos on diarrhea alone. So check. Now, there are lots of pieces of info already published out there. So I won't go into details of all those. So let's stick to what we have here right now. So if you're interested in knowing more about diarrhea, check my channel for that. So in irritable bowel syndrome, the diarrhea in affected people will be waking them up early in the morning hours, and could be after meals. Although there's what we call gastrocolic reflex in other normal people, but they know, the affected people will know that this has been happening like this over months and years. They might have pain before stooling, and they could have what is called tenesmus. That is, even when they have emptied the bowel, they'll be feeling as if they were not done. And people like that might remain in the washroom or toilet or giant for several minutes, and others will be wondering what are they doing there. Although they've emptied the bowel, but they have tenesmus. And the stool could be stained with mucus, might be very large in volume, may be bloody, and they could even be waking up in the middle of the night or to defecate. That's nocturnal diarrhea, like they have as part of complications of autonomic dysfunction, secondary to diabetes mellitus. Greasy stools are not associated with irritable bowel syndrome. So if the person is complaining that the stools are greasy, look for the cause. When it is about constipation, I will not waste your time here going into details as far as constipation is concerned. I have published some videos on constipation. You can check my channel for that. But briefly right now, the stool will be hard, pellet-shaped, and they will have tenesmus. That is, feeling of an empty bowel even when the bowel is already empty. The diagnosis. We have what is called Room 4 criteria for irritable bowel syndrome. Under that, there will be recurrent abdominal pain at least 1 day per week in the last 3 months. And that will be associated with 2 or more of either defecation, that is, the abdominal pain will be associated with either defecation or change in stool frequency or change in stool form. So 2 of those 3, that is defecation, change stool frequency, changes in stool form, will be associated with pain. If that's the case, that's Room 4 criteria for irritable bowel syndrome. Managing criteria for irritable bowel syndrome will include relief with bowel movement. There will be looser and more frequent stools, the passage of mucus, and incomplete emptying, that is tenesmus. So if somebody is using managing criteria, the individual will look at this. But you can use Room 4 also and match the 2 to make the diagnosis. Cruise criteria is less useful in medical practice, so there's no need wasting your time to go into that. But for medical students and nursing students, you need to know that in case you are given the MCQ, that there's something called that. But in medical practice, we don't use it. Evaluation, particularly to nurse practitioners or physicians to be, or those that are practicing in some other parts of the world and they are not acquainted with the modern practice, we could grab this. Thorough history of onset, cause, duration, effects, and so on. Then physical examination, past medical history, particularly the use of laxatives, antibiotics, or that is to those who are having diarrhea. But to those who are having constipation, You need to find out if this person has been using anti-diarrhea, because when there's diarrhea and you are using loperamide or anything to stop the diarrhea, then you may be treated to constipation. And of course, you need to rule out the use of anticholinergics here, because anticholinergics will have dry mouth, urinary retention, constipation, blood vision, and so on, including arrhythmia. So if somebody is on anticholinergics and now down with constipation, and you are now thinking of irritable bowel syndrome, you are wasting the time. History of medications, allergy to food will give you a clue, and of course also to immune diseases. Now, thyroid problem like hypothyroidism will give you constipation. Hyperthyroidism will give you diarrhea. Now, inflammatory bowel disease, Crohn's, radiation, chemotherapy, psychiatric problem, abuse, anxiety, like I've listed earlier. We need to rule out all these. Fibromyalgia, chronic fatigue syndrome, depression, power surgery, like short gut syndrome will lead to diarrhea, right? And you need to find out what have you used, because whatever must have been used could have altered the symptoms right now. Someone having diarrhea that's taking some loperamide could be having constipation right now. What are the aggravating or relieving factors? And with that, you will know the triggers, right? And what time of the day? Remember, just a while ago, I've just said it. The diarrhea will be likely nocturnal, that is at night, or waking them up in the morning. Characteristics of the stool is either loose stool and severity of the pain. If you want to run some laboratory diagnosis, which is not necessary if you don't have the equipment or you are not equipped at a center, because it's not everybody that is having the privilege of having everything around. You could make the diagnosis clinically, but if you want to run a laboratory, yeah, for diarrhea, you could have fecal calprotectin and fecal lactoferrin. In that wise, you are trying to rule out inflammatory bowel disease. Celiac disease could be ruled out using antigliadin antibodies and anti-transglutaminase antibodies. So with that, you'll be comfortable if the results are negative that you are not dealing with celiac disease. Giardia antigen detection or nucleic acid application assay for Giardia, rule that out. And if you can't do calprotectin or lactoferrin, then do C-reactive protein levels. You can have complete blood count in case the stool is stained with blood, either melina or frank, or that is hematochezia or whatever. We want to know how severe that is. And particularly, somebody having diarrhea that they take food, malabsorption is out, they may be now down with diarrhea because the nutrient that will help them to build the blood is not there in the system because it's all out. They've gone to the washroom or toilet or joints. When the diarrhea comes over. Colorectal screening, that will be age appropriate. Now, people 15 and above, you have to do colorectal screening so that you'll be sure you are not dealing with colorectal carcinoma. Anorectal manometry and balloon expulsion testing to rule out dysnergic defecation in severe constipation. There are alarm features. The alarm features will let you take appropriate action and make appropriate referral immediately. 1. Someone is 50 years old before the onset of symptoms, then refer for further detailed investigations. If there's rectal bleeding, hematochezia, refer. Notional diarrhea, like I said, that is a signal that's autonomic dysregulation, particularly found in diabetes mellitus as part of complications. But It's not only in diabetes mellitus that I'm going to find out, but when that is part of the complaint, then you need to do more. Progressive abdominal pain. So the pain is getting worse, day by day, week by week. Unexplained weight loss. The patient is telling you, I was weighing 80 kg or 180 pounds, but now I am 70 kg or 160 pounds. And it's not that I've been exercising or reducing my food or I've never changed my diet. That is unexplained to the patient. Then you need to do something more. Laboratory abnormal results, giving you clue that you are dealing with something more serious than irritable bowel syndrome. If there's family history of irritable bowel syndrome or family history of colorectal carcinoma, then you may not limit the constipation you are dealing with or diarrhea to the assumption that this is irritable bowel syndrome. And if you find all of the above, if you find any of the above, please do colonoscopy. When it comes to differential diagnosis, I will go over each possible presentation separately. If it is diarrhea predominant, we might be dealing with celiac disease, might be dealing with colitis, maybe pseudomembranous colitis or ulcerative colitis. Any of them. It could be bacterial overgrowth and could be inflammatory bowel disease. When we are dealing with constipation predominant irritable bowel syndrome, it could be organic disease, could be dyskinesia, could be slow colonic transit, anticholinergic, cholestyramine, opioids, cystic fibrosis, or colorectal carcinoma. The cause of irritable bowel syndrome could be, and this is very essential, could be unchanged in about 30 to 50% of the affected people, could improve in 12 to 38%, and continue to get worse in 2 to 18%. And with that, I've come to the end of this first presentation as far as irritable bowel syndrome is concerned. The next presentation will be on treatment. That may be shorter than this, but you need to know what you have to do. It's not all the time you need medication. And the types of medication you can use and for what purpose, I'll go into details of all that. So thanks for listening to my presentation. Kindly subscribe so that you can get all these presentations immediately they are published. My heart goes out to all the affected people. Thank you.